Good morning from New York. Can you hear us?
Yeah, we can hear you loud and clear.
Okay, so I'm Dr. Kinney here, director of the Cath Lab, who will be the
Yeah.
operator, and then I'm assisted by Dr. Huda, who is our faculty here. I have Gaurav Kandelwal, who is trained and will be joining India as of January 1st, fully trained from us, and you will see him helping me doing the live case. I have Rajiv Samtani as a fellow, Pablo Asif as our technicians, Will, Ashley, our nurses, and I have Kiski, who will be our imaging faculty here from Sinai. Good morning to everybody, and we are going to, if you can introduce your faculty, we can start the case.
Yeah, Dr. Kinney, I am Dr. Ali Faisal. I am a cardiologist from Calicut, down up north in Kerala. I'll give my mic to my colleagues who are co-chairing with me or moderating with me.
Hello, Rustem Dautov. I'm a cardiologist from Prince Charles Hospital, Brisbane, Australia. Looking towards interesting case. Thank you.
Hello, I am Dr. Praveen G. Pai from Amrita Hospital, Cochin.
I'm Dr. Saravanan from Coimbatore, Tamil Nadu.
And beautiful. And I'm here. Dr. Samin Sharma is supposed to be there, but in a different place.
Where are you, Dr. Sharma?
Yes. Right now I'm in Mumbai.
Okay.
And will be just, and so I'm so happy that Dr. Keeney could get all the staff, including the patient. This is, it's a Thanksgiving weekend, very big in India. I mean, in America, and they're able to gather the team and the patient for this lively, very interesting case. So I think if everybody is all ready, they will allow Dr. Keeney to present the case and go forward.
Okay,
Sure.
Can we show the slides now? So myself and Dr. Huda has nothing to disclose. So if everybody can see the slides, this is a 87-year-old female who actually presented way back in October with angina class 3 and dyspnea, went to her private cardiologist, and then they did a stress echo, which showed a multi-vessel, actually multiple wall motion abnormalities. So though she's 87, not significant risk factors, controlled hypertension and hyperlipidemia, for which she was on medication with a metoprolol, a beta blocker, calcium blocker, as well as statin. So she presented because of class 3 symptoms, sent for angiogram, which was done on October 31st, which revealed calcified 3-vessel disease with the left main. You will see, I'll show you the angiogram also, significant calcific lesion in the RCA, bifurcating distal left main with the EF close to normal, 55%. Because of bifurcation calcium 3-vessel disease, her syntax at that was 30. And we all know with high syntax score, despite the age, we should always have a heart team discussion. So she did have a heart team discussion, but for obvious reasons, she underwent, both the surgeon, the family, and the cardiologist opted that she should undergo percutaneous revascularization. So she underwent a rota DES of the RCA. During that time, she actually developed a lot of slow flow, although the final results were very good. And subsequently, the residual syntax score was 22. So this is a right coronary artery. You will show that it is an anterior takeoff, ostial 90% calcific lesion. Again, mid RC also 80-90% calcific lesion. This was the case that was done in October. So if you see here, we are trying to show that when you are doing ostial RCA rota, you need to use what is called as an extra support rota wire, and you are doing rota from outside, actually starting way back in the aorta from the guide, so that you can take care of the ostial lesion itself. So it was a 1.5 bar, and after that we did actually promise later 2 stents, and this is how the final results were after giving a lot of vasodilator therapy. A lot of slow flow was there with EKG changes. She actually required temporary pacer at that time.
And you can look at how calcific left main is. See that left main and LAD is so calcific on other side.
Yeah, you can see that now it's angiographically tram track calcium of the left main, LAD, as well as the circ. So today we are planning IVUS guided PCI of the calcific left main. So going back to every case, we always go with is it a case appropriate or no. So despite her being elderly, because of her left main and 3 vessel disease, it becomes maybe appropriate. But then once you have heart team discussion, these cases do become appropriate. So the recent guidelines, what did they say? Assessment and predicting patient risk was very, very important, that when you are not sure what is the right thing to be done to a patient, heart team is very important. We did that in this case. Other things, what are the factors we need to consider is STS risk score in every patient. Though she's 87 with no other comorbidity, her STS was just about 2.5. And syntax we all calculate, and we all know her syntax was high. One thing that they have added in the current assessment is the assessment that was never considered in the STS score, which is presence of cirrhosis, frailty, and malnutrition. So as they get older, malnutrition and frailty becomes very important. Sometimes your numbers may not look it, but then if they are frail and malnourished, the surgeons are not comfortable in taking these patients to the OR. So here we are today with a syntax, residual syntax of 22, STS of 2.5. So just a couple of things that we need to go over, that this patient, we are dealing with a complex left main bifurcation. Simple is very easy. You have distal left main lesion, or you have a distal left main with one vessel involvement only, and the other vessel is not involved. If left main disease, if you go to the complex side, however, you see distal left main and both the vessels are involved, as well as if it's not involved, it could be less than 50, but then the lesion length also could be longer than 10 millimeters. So this puts it into a complex bifurcation left main, and on top of that, severe calcification like we see in this case. So studies have shown that when you see the percentage of complex bifurcation left main is 32% or so. So when we see this kind of cases, several trials have shown that you should go with upfront 2-stent strategy, especially the DK Karash 5 has shown that. And now the question comes, this though our EF is just about 55 or so, with this complex intervention, do we need any support? So with the EF less than with the EF that is just about okay, we could either use IABP or Impella. CHiP showed slow flow and a lot of rotational atherectomy complication in their RCA. So we decided, because we are able to access, our access site was very good, that we will use just a simple Impella 2.5 in this case. And this is to say that, so she falls into category green, where EF is more than 40 complex PCI. So either IABP or Impella, but we have opted for Impella in this case. So having said that, I think we can, I'm going to show you the angiogram from today. If you can show the angiogram. So this is the right coronary artery. Looks very good.
Great.
Yeah, the Impella. So her creatinine, when she first came, October was 0.8, today is 1.3. So we did not take LV picture. Echo was done about a month back, so there was no LV thrombus, so we just used that. So you can see circumflex disease there. Ostium is involved. And this is just to say, just on cine angiogram, tram track calcium. I don't think we need any kind of imaging to say, yes, this person needs some kind of modification. So this is where we are. So hazy distal left main, and there's a proximal LAD lesion also in this case.
And Anu, if you can just comment on it, IVUS versus OCT for the imaging, because I know the creatinine has gone up a little bit, and we'll ask the other panelists if they have any other thought on this particular case. And I'm sure the use of Impella always comes questionable when you have low ejection fraction, but in this case could be appropriate with the knowing that right coronary became slow flow and so difficult, this heavily calcified vessel, you're working on it. If it develop slow flow, could be very catastrophic. But the point two, basically, one emphasis once again, why Impella versus balloon pump. Second is the imaging. OCT versus IVUS in this particular case?
Now, distal left main, but the left main is long enough. OCT can be done in this case because she's elderly and there was a bump in creatinine. That's the only reason we did not like OCT. But in every case, especially in defining calcium, understanding when to use what kind of device, I think OCT probably is better than IVUS. But if you want to just do left main and understand optimization of the stent and all that, IVUS is probably better for the left main itself. So it's all what the person is comfortable with. But we can see I think right now our plan is we will do rotational atherectomy first because of the significant lesion, and after that we can do the imaging to understand if the circumflex needs some kind of what kind of modification device, if that's okay with the panel.
Dr. Kinney, Dr. Sharma has already asked the question. So regarding the use of impella here, so it is a routine practice in a patient like this to electively put the impella, or if there is an evidence of any hemodynamic compromise?
Good. Excellent question. So in this particular case, yes, in any complex PCI, I think the complexity which was defined, I went through the slide slightly faster, because if your syntax is very high, calcium, low EF we are talking 25 to 40 or so, those kind of cases, yes, you do elective impella rather than wait for any complications to happen.
Okay. And again, the practice is to use impella rather than IABP.
Now, in this case, if there is no impella available and a balloon pump is something that is available because the EF is near normal, nothing wrong in using IABP here.
Okay.
But
I think that's very important point.
plus the groin access. Remember, before we do impella, we have to make sure access should be okay, pre-close should be doable. So this person had a good groin access. So in that situation, yes, we decided let's go with impella just because it's a complex left main.
Yeah, so I think your decision for impella was a little more swayed because of what happened with the right coronary. Was very calcified, but what happened with the right coronary, and knowing that if the balloon pump may be okay, but if you have a choice and you can do it, even in the normal ejection fraction, as you know, based on the earlier trials, at present in United States for the complex CAD, even with the patient with the ejection fraction more than 50, impella is reimbursable. I mean, it does not mean that you have to use it in every case, but key is that there are enough data to show that does cause less hemodynamic deterioration and acute complications.
So now we selected 1.75 bar here. So we actually, before you guys came live, we had wired it with the rotawire. We have regular floppy rotawire there. So we have it placed in the normal segment of the left main. I did my 3 things, which is here your
you
knob,
don't use
you go forward backward, and then
you don't use an extra support wire here?
You don't need extra support wire for this case, but for the right coronary artery we did use. So extra support wire maybe we'll use in like 10% of the cases, or mostly ostial lesion or distal lesions. Like if you have a distal RCA PDA lesion, AV continuation, and your burr has to reach there, that's the time you would use it. Here, since it is just proximal, we will not need it. So I did my 3 steps, Dinah.
Do you do IVUS up front in this case?
No, in this case, we did not select it just because angiographically we knew that was significant calcium, and left main was significant. So we thought let's do some kind of first round of a burr, and then we can go.
And
then we can do imaging.
Is your strategy up front provisional or 2-stent?
Like I mentioned, since this is a complex left main and it's like 1-1-1, I think it's better we go with 2-stent strategy, as shown by DK 5 trials, where they've shown that if you have complex bifurcation left main, better you go with the 2-stent strategy up front rather than go provisional and use bailout, because the use of bailout was over 60% in complex lesions when they did provisional. And when you use bailout is when you start having a lot of complication, and risk of stent thrombosis also is higher.
In my practice, I would do probably a single stent in this case after rotablation. I was guided 87 years old, good left main to LAD active stent. Provisional.
Yeah, I think what happened is in this particular case, we are not seeing a lesion in the ostial circ. Maybe one of the model we will show. If there was a lesion, angiographic lesion in the ostial circ. So once you have 111, I know the EBC1 trial also showed that stepwise, if you want to go with a two-stent approach or go upfront two-stent approach, probably okay. So,
Dr. Kinney, you would have done a large number of rotas. So when you're doing a left main bifurcation, no? So is there any situation where you birth the left main to LAD and complication occur into the circumflex?
I mean, good question. So I think one of the reasons why we select rotational atherectomy, and I think for years together, and there are publications also that when you have bifurcation lesions and when you have a lot of calcium, the way the rotational atherectomy works, you see that the whatever the diamond chips are only in the front, so they will burr the lesion. In that situation, the plaque shift or calcium or any kind of a shift that happens to the side branch should be lower. So we'll take a picture.
Yeah. Okay.
Rather than
Dr.
having
Kinney.
any complication. Yes. Go.
Dr. Kinney, sorry. The reason for temporary wire here?
No, only because she's elderly patient. Otherwise, left main and dominant RCA, you do not need it. I think the rotational atherectomy has done its job. So we'll go with the side-by-side wire, and then we'll wire the circumflex also. We'll IVUS both, right? And then we can decide.
Sure.
If there is ostial circ, yes. That's a point well taken because she's elderly patient. If somebody wants to do provisional stenting, that's not a bad choice either. This is our workhorse wire. Okay, get the IVUS. You want the wire?
So key is
right?
that IVUS is right now, will tell you a little more in terms of course, the effect of rotational atherectomy, but also try to see the ostial circ, because you're not given much dye because of high creatinine. This is the kind of case, if everything, in the end, you could do just one OCT run to see how the stents are fully opposed and so. And of course, IVUS require interpretation. OCT, with so much algorithms are there, they really tell you basically with their algorithm that your stent is fully opposed and so. But question here is whether there is an ostial circumflex involved. If ostial circumflex, just coming back to the point, our policy has been unless patient cannot take DAP, we'll try to go with a two-stent approach. Whether it's a mini crush, that is our favored one. We rarely use a DK crush, but that is also is very good approach. We do not use culotte. I know a lot of people use culotte, but we never use a culotte by definition in our lab.
So I'm wiring the circ also now. So what I did was side-by-side wiring of the. Give me some dye there. Yeah.
Why don't you take one picture here also? Because it was not done before. Because of creatinine, maybe we can understand the ostial circ lesion a little better angiographically, and of course, you might do the imaging.
Okay. Let's just take a better picture. I'm trying to see if I can go caudal. Okay. Good?
Yeah.
Go. Okay, get that.
Well, let's get our comment from our panelists there, because to me, it's a long lesion of the circumflex also.
So you do you plan to birth the circumflex here with or after the IVUS you?
After IVUS we can decide. Our plan was just to use a cutting balloon, and if it's really a lot of calcium, then maybe even IVL.
IVL, okay.
Yeah, I would remember this very angulated circ. I would say these kind of cases we should keep away from rotational atherectomy, because that's where the trouble can occur. One, it can create that gutter at the angle. Secondly, high chance of perforation. So in this case,
Okay.
if you cannot open the lesion, plaque modification by your high pressure cutting balloon or IVL, then only I'll resort to the rota in this particular case. So maybe our other panelists can say that how would they treat if it's a very calcific long lesion of the circumflex, as you
start
can
the
see
IVUS
here.
there.
Okay, check the image.
IVUS is not crossing the
Can
lesion.
you show the iris?
Yeah, but see that at that level, there's no disease.
Okay, I will
But
start
Got
to
the
work.
iris.
angiographically, there is,
Yeah,
you can
just
see
one
that.
cordon chunk of calcium. So coming back. Yeah, here's also the one cordon calcium. Yeah, so tight, block circ.
And that's
Yeah.
osteal circ, yeah.
Yeah, just one cordon.
So there
Some
is
branch.
osteal circ disease and left
Yeah,
main
here's
disease.
tight, so tight. Come to the left main. Yeah, right. Stop.
Okay, good. So osteal circ give us a calcium. Look like it was
Yeah,
180.
1 to 2 cordon calcium.
Yeah. So we
And,
could
I
probably try
checked the
cutting
type.
balloon, right?
Yeah. Not so much calcium in the circ.
Okay. Yeah.
And,
So we have a cutter balloon cutting. Or trio is good.
Okay,
Or
I will
you want to go
check.
3 to 5?
1 second.
No,
The
trio.
ER.
I think trio will be good.
Yeah. The ER to
Yeah.
ER 3.2. Yeah, one size down. 3 always good. Safer.
Should we IVUS the LAD now?
Yeah. Of course.
Okay, I'm going to IVUS of the LAD.
The left main side is follow.
Left main is 4.
Yeah.
Okay.
So let's ask our panelists also. Now, based on this,
There is a question from the audience, Dr. Ajit. Yeah.
Dr. Kinney, your iris was held back at that lesion in the circ beyond the ostium. Do you think there's some calcium there and you would run a rotablator once there before you get in? I'm not rotablating around the ostium of the circ, but just that lesion where the iris got stuck.
So that could be just the angle also, the way it was going, because you see it, when we did the IVUS itself, we did not, there was, look at the lumen where the IVUS was stuck was large enough. That's one. And I think Dr. Sharma just mentioned also is angulated circ and try to avoid rotational atherectomy in the angulated area for the risk of one lot of wire bias. Now you see that
Other
the IVUS
question
is not
is,
going
maybe you
further.
can-
Yeah. Mm.
So
Yes.
no,
Can I
that
start?
IVUS versus OCT in this tough lesion, which is more, can be advanced better. So I think the other question of the Ajit was very important, that if there is truly a disease in that circumflex, and we know that calcium proximally was only 2 quadrant, but what if there is a circular calcium in that hazy looking napkin-like, ring-like lesion, and what we need to do a modification? I think it could be that maybe just do a balloon and see if it opens or not, and then you decide. By angiographically, it doesn't look that bad, but
No,
clearly the IVUS
angiographically, we plan to cover that.
Yeah.
You see? Yeah,
Okay.
we are going to cover that. So we're going to go with the cutting balloon and take care of that.
Okay, I
But
start pull back.
LED, yeah, start pulling back of the
The
LED.
mid LED. Yeah, so tight.
So
lesion.
now this is where we are.
Yeah, I see some branch. Yeah, here's also
Now,
some.
mid to distal LED, there is moderate
so
lesion,
tight.
which we do not plan to intervene.
Here's so tight. Mid LED. Yeah, 1 to 2 cordon calcium. Yeah, diffuse disease. Not healthy lesion. I see some big branch. Yeah, I think. Oh, it's a left main.
That's left main.
more than
Okay.
3 quadrant calcium.
Yeah.
Yeah.
So I didn't
And
see
some
it
interruption.
landing
Looks like
on-
there is some cut in that calcium by the rotational atherectomy.
Sure, I saw also some revelation, so it means loader worked. It didn't cross to the normal part.
Good.
The diffuse
So
lesion
I
in
think
the
we'll go
LED.
with the cutter to the circumflex first, and then we take care of the LED.
But I would
You
say
may
that
have
based
difficulty
on what
getting
we
cut.
saw,
Mm.
what
Are
I,
you- cutting
why
balloon
not go with
will
a high
go, I
pressure
think,
balloon
yeah.
first to that second lesion, because second lesion may give a
You are
trouble.
planning to use a cutting balloon now?
I guess the
Yeah.
cutting
Right.
will have difficulty going there. That circumflex looks very tight, that one.
Okay, we'll try.
Let's try. I think this will be a good test. 3-0. My prediction is cutting balloon with our
32.
Wolverine will not go to the second lesion, which we are concerned. And if not, then you try a high pressure. If a moderate, if it doesn't open, we know that if that did not work, IVL will not go. Then we do a rotablation, maybe a smaller bar 1.5.
High pressure 30 for LED.
Hmm?
This is for LED.
LED?
Yeah.
No, circumflex. What
No,
size is this?
Cutter.
Yeah,
Cutter. again.
3O.
That is cutter.
Give me the cutting balloon. So we're going, we will try the cutter to the circumflex, otherwise get us a 3O 15 high, no, then get us a regular balloon, okay? 12. Have it ready if the cutter does not go. So if you see the circumflex where the IVUS got stuck, we are trying to plan, take care of that also and stent that area. Okay, let's see how this behaves. Can actually take care of the ostium, no?
Let me just go. 1, 2.
Okay.
No.
Give us a regular balloon then.
Non-cutting balloon, yeah.
Yeah. We'll not with the high pressure, we'll go with the 12
So
millimeter
this
balloon.
actually, yeah, this is a very important point that IVUS made us believe it's a 2-quadrant calcium and we'll be able to go through with the cutting balloon or so, the scoring balloon, but clearly that with the angle, length, and of course, even those 2-quadrant, likely on the inside aspect of the left of the circumflex, didn't let the scoring or cutting balloon go. So now I think it's the right thing to go with to downgrade to our regular balloon or a high non-compliant balloon and then see how things are. Before it may boil down to, I know everybody asking that do you do the rotation atherectomy? If this device does not go, then clearly it's the case that you use a small rotablation bar. Here, this balloon went very easy.
No, this is a compliant balloon. Okay, we didn't
Yeah.
take once we know cutting did not go, we went with the compliant. Go, dilate.
So what is the reason for using the compliant balloon, Dr.
14.
Kinney?
So that you're down. The balloon itself, the material, the compliance is lower, but it will dilate. If it does not dilate now, so we have to create a channel track for the cutting balloon to go. So it is just the angle, I think. Look at that.
Yeah.
Look at that, almost 90-degree retroflex circumflex. That may be the reason, though the IVUS made the turn, you see it? So I'm going to do once more is try again here. Go up again. Down. So should we try cutting balloon again or we think we are good here?
No, cutting balloon, cutting balloon. You had to use cutting
Okay,
You
go
balloon.
can
here.
try one more time, no?
Yeah, okay. Get the cutting balloon quick. And then we'll dilate the LED. But panel believes that we should do 2-stent strategy here.
I think,
You have to now.
yeah, majority believes.
Okay, the reason also is
One
having
person
done,
disagrees.
okay, now having done all this to the circumflex and we do a provisional stent, if the circumflex then has, significant lesion or slow flow, anything happens, I think subsequently recovering the circumflex may be harder. So now we are trying cutting balloon.
So in a lesion like that, what is your usual pattern of stent usage? It's a decay crush.
I mean, we favor mini crush just because
Okay.
the steps are fewer, but the world believes in decay crush.
Although a lot of people in Europe, they use still culotte.
Oh,
Okay.
In EB1, there are a lot of cases, but got the culotte in the 2-stent approach. The crush was very little.
you know what other
Let
thing
us
I was thinking?
Start cutting
Let's
from
dilate. No, let's
Yeah.
dilate the left main. We did not dilate the left main. No, unnecessary. Okay, go. It's not. Go up here. He's saying dilate here. We did not dilate the left main to LED also.
14.
Okay, good. Down. So I'm going to rewrap it and then get into the left main.
What is the size of this balloon?
3O.
3012?
Yeah,
Yeah.
no, this is a 6,
306
cutting balloon
Wolverine.
6.
Sorry, this is the cutting balloon. Yeah, sorry. Yeah, 306. And earlier balloon which you used was a 3015 compliant balloon.
12. Okay, now it went forward a little
Yeah,
bit. Go.
Dr. Ajit.
Little
Dr.
bit
Kinney,
a millimeter. Yes.
if this doesn't
Down.
go, maybe it's the angle, you're right. I think we should just get the guideliner on top of that balloon, old balloon, get it down and then pass the cutting
Okay.
balloon through that and then pull it back.
It will
You're
go now.
crossed.
It went in.
Yeah. The same which
See,
we always
other-
see.
Yeah.
Sorry.
So what we were trying, yeah, Dr. Sharma mentioned what you were
No,
talking.
the same, that once your nose of the balloon in the lesion, particularly this, whether it's any of those scoring balloons and so, it's okay to dilate there, because that will make a room by creating some cracks in the circular calcium, and then it will advance. And this was the classical example, as you saw it, the gradual advancement, bring the flagstone there, Wolverine, and then gradually making a room. So that is okay. If it doesn't cross, you go further, start dilating. As long as the nose is there. If nose is not there, then you are in trouble. Then you have to go with the, just pointed out, going with the over the wire guide liner or Godzilla. But otherwise, you just go inch towards the plaque modification using the Wolverine in this particular case.
So this is a poor
Dr.
man's
Kinney,
test we
Dr.
are doing. Yeah, good. Go
Yeah.
up here. Yeah, go up here. See, again, there was a little.
The deflating, deflating the cutting balloon, can it be this rapid or can it be a bit slower? Because the different school of thought of deflating slowly.
Or yeah, that's a good point. Or more important, when we started using cutting balloon in the beginning, the teaching was that when you second time inflate, you go slow. Because what happened is the balloon, the material in front of the blade, if you go rapidly, may cause a perforation. So, or perforation of the balloon or rupture of the balloon, basically. But whether you should go a little
right?
slow in terms of deflating is, I think,
Okay,
it's
down.
questionable. Whatever the practice is, people want to do it slow, that's okay. But yes, what makes sense that your second or third inflation when you're doing after the first one, that you go a little slow, you give time for the balloon material which is wrapped now in front of the blades, time to really come off the blades. So slow inflation, but rapid deflation is, I would say, is a practice, matter of practice.
Okay.
But anyway, but Anu tried multiple times that stent will go or not, tested by sending this the Wolverine few times, and it went in, and that lesion which was questionable, where I did not cross. I'm sure there was a lesion, but was not a circular calcium, because we had got a very good result of this Wolverine that nicely expanded.
So now I'm going with the 32530 balloon to the LAD.
Dr.
Yeah,
Sharma, Dr. Deepak here. Despite having the maximum experience with rotablation in your center, it's good to know that you've given a lot of importance to safety in this particular elderly lady, 83 years. You wanted to try to avoid doing a rotablation into that retroverted circumflex. It looks almost 90-degree angle, the circumflex ostium. Could you tell us what sort of angles would you try to? You have a higher threshold for rotablation. When would you want to avoid rotablation? In what sort of angles would you avoid that?
Yeah, so I mean, clearly, if there is a retroflex, circumflex, which is just like this, there is a 110, 120-degree angle. If it is less than 70, I think it's okay. And I'm sure Ajit will say the same. Personal experience have been these horizontal 90, 110, 120 left, 110, 120 degree angle. Their rotation atherectomy is troublesome, and the goal there now, I would say, in this case, having done so many, I'll try to avoid rotational, but yes, that if there's no other device happens, then you have to resort to it. So I think opening the ostium a little bit and followed by, I would still try the IVL if lesion does not expand before resorting to the rotational atherectomy. So I think the question is, should you avoid it? These kind of cases you want to avoid. In retroflex, circumflex, which is 90-degree, 110, 120-degree angles, if it is 70 or less, that is okay. But they are very tortuous, like in this particular case, may create a trouble. So idea there should be, try to not to do a atherectomy, but just to say that if nothing else works, then you have to resort to rotation atherectomy with a small burr, and careful advancement of the burr will be the approach. Now, want to tell us what
Yeah.
you are doing now?
So we did
Yeah,
used a
can you-
3 to 5 30 millimeter balloon. We dilated. So always do a cine to make sure that it's a fully expanded. So looks like it's a fully expanded. We would not need any further lesion modification. If everybody agrees, we could go with the stent.
Dr. Kinney,
Now-
why is such a long balloon? You usually use this?
Yeah, so we carry 15, 20, 30. We know we are going to do a long stent. So instead of using a shorter balloon and use multiple times, we just like to use a 30 millimeter balloon. We are going to use a 33 millimeter stent here anyway. So you can finish, faster.
So if you
Yeah,
were
so
to
I
do
think
a
what-
Yeah.
so if you were to do rotablation in a retroverted circumflex, what precaution would you take? Would you downsize the burr size, or what exactly would you take care of? Like,
downsize the burr and use the floppy, rotor floppy. You cannot use the extra support, will clearly create the gutter. Downsize the burr with a usually 1.25 or maximum 1.5 and using the floppy, rotor floppy wire and slow advancement. And you can see if you're really having a significant deacceleration, then you stop. You know that
3 to 5,
going
3.
further,
Oh,
going to create a
circumflex first.
major trouble. So you want to
Get me a
basically
circumflex.
go.
Key, length
Yeah,
of the
so
circumflex.
okay, start is 3.0 because we didn't cross the normal part of the distal LED. So maybe gentle pressure or 3 to 5.
3-0.
So those will be the steps. The smallest bar, 1.25, because you don't have to
No,
worry about the big
circumflex.
size. You need a little
This
cut.
is
You just need a little cut into the circumflex.
this is
Length.
12 balloon. This is 12 balloon.
Interelastic
I
lamina.
think
And
24 is okay. This is 12 balloon.
23.
Please.
So we plan to take a 3/23 to the circumflex and 3/33 Zions to the LED to left main, 3 to 5. And then I think left main, we will post dilate with a 4-0.
Okay. Dr. Ajit.
Dr. Kinney, there is a lesion on that bend. Would you be leaving that alone, or
Yeah, I think
just
we mentioned that to begin with, that we will leave the mid to distal LED alone. Then it will become complicated.
Yeah.
3 for the sir.
What's the circumflex length you got on the imaging?
So from the start of the pullback to the bifurcation is 10, but we did not cross to the distal
I did
landing.
not cross the lesion.
How much you got? 10?
Yeah, 10, but
No, this is 23.
but I think
3
23.
or 20.
I would
No,
say
we are going
3 or 20.
23. Yeah. I'm doing eyeball, and then we have imaging, so we just compare. That's it. So we are going 23, 3 or 23 to the circumflex. So when we are doing mini crush, that's we always do. You can show side by side mini crush video of the 3D bifurcate. So always go to the side branch. So here we may have issues knowing that. But we had done the multiple tests that a deflated cutting balloon did go. So I'm going to go to the caudal view, same view where we had seen. So go distal.
The
That's how
Zions
we
went
will
very
park it.
easy.
Yeah,
Yep.
and then
I thought it would be a
we are
little difficult to advance, but the stent went because of the plaque modification which was done, step by approach, and particularly cutting balloon was quite helpful.
3 to 5.
And of course, if there was an area,
stent,
if
LED
needed,
stent.
this was the case where you will use IVL. If you think your stent balloon, your balloon did not expand, IVL to me will be safer, but some of them you cannot advance the IVL because of tortuosity, because of long lesion.
Keep it
Then
close.
you have to resort at the last as the rotational atherectomy. And the orbital, some people say, what about orbital? I can tell you orbital cause the tortuous lesion. Orbital creates more trouble than the rotational atherectomy. So orbital will not be the right choice in this particular, and orbital will be coming soon in India. In next, as I mentioned in my talk this morning, that the second quarter.
Okay, so here everybody can see it. The steps we are going to show of the mini crush. We will place the side branch first. It's playing there, the 3D video. So I'm going to pull the side branch of a millimeter into the left main. good, right?
Yeah.
Some dye. Want to see now?
Okay.
Just little dye. I'm going to pull back a little bit
Yes.
more, right?
Yeah.
Dr. Sharma, it's always a discussion about
Okay.
stenting left main. Do you stent in the body or come to the ostium, even if there is
Yeah,
no
so
much
that
disease?
very good point.
Good.
I know that
Go.
the lot of people will come up to the
Going
ostium,
up on
but you know,
circle.
ostium always can
Yes.
create a trouble for the future
up.
because then you
Yeah,
have to
go
come
to the
out.
circle.
So I basically,
12,
we say that if there is no beaking
14.
of the left main, not even a 5-10% lesion, we try not to go to the ostium and just stop in the
14.
mid left main. I know that a lot of people in Europe propagate that you should come up to the ostium, but remember ostium to cover, you have to then few millimeter out, which we all know the drawbacks of that particular technique.
Some
And
dye.
later on, we are engaging the guide difficult, maybe guide may disrupt
Okay,
the
now I have to pull
ostium.
this
And
back.
so,
We have to take a cranial.
Yeah. I'll go
okay,
to
they have
cranial.
put the stent there.
Yeah,
And
we'll
now
put the
we need to
circumflex
convert.
stent. We are
Okay.
adjusting the left main and we'll just go cranial to confirm the distal edge. So you can see the side by side animation there. Okay. Yeah. Hold you. This is the, yeah, give some dye. Want to pull back a little bit because we have to have enough space for it to pot. Okay. Okay, good. Go up now.
Going up.
And this is a
Low
3.5,
pressure.
low
33
pressure
lines.
only. 12 only.
Yeah, we are going only, yeah, 10
12.
atmosphere to
Okay.
deploy because proximally then we will post to 40 down. Get me a 408 high pressure balloon for the left main.
10 only.
Now, this is just
So
to our audience. It's a Zions Sky Point, which is not available here yet. Hopefully, come soon. But basically, the stent is the same. It is only the balloon delivery which has made it more deliverable. And as you saw that circumflex, the stent bend. I'm sure many stents will have trouble to make that bend even after the plaque preparation which was done.
So now we have a stent placed, you have to recross. The question always comes and there's always a debate. Do you recross first or do you recross after you're done the pot of the left main?
So would it be better to recross after doing a higher pressure dilatation at the circostium with the appropriate size balloon, or is it better to cross before you dilate? After
Either, I mean,
without-
either way is okay. What we are, I think we always try to say, and we also promote in the app, is you try to recross first. If you could recross easily, good. If you have issues, which means that the stent needs further optimization in the left main, then do that first. A lot of people will always argue by saying that it may go behind the stent strut in the left main. When you're recrossing, you may have issues. So a lot of, if they think that that's what the, so we're going to will recross.
We are not taking.
We'll take a picture. Wait, I have to recross that. Give me some dye. The guide came out. Some dye.
Need to engage.
the wire came out?
Yeah. We have the wire has come out.
No, let's go.
Okay,
Left.
now there.
Inches.
I will try to recross the circumflex first. This is the LED there. We'll go to the caudal view and understand. First of all, let's take a picture to make sure our stent is good. Okay, ready?
Ready.
If you have trouble, then we have our 408 millimeter balloon ready to optimize the left main. Give me a new fielder wire maybe. Now some die, small branch. Despite I mean, lesion preparation, is still the circumflex looks hazy there. Okay, this wire is gone.
Build.
So the same wire, we left it in the guide and then used to recross. But having trouble with the same wire, we're just using, the fielder was in the side branch. This is a polymer coated wire, which is easier to gain access to the side
Yeah.
branch.
Was a field wire, field FC?
Fielder, regular fielder. Okay, now get us a 3012 balloon to the side branch, right?
Yeah.
The same.
312 hybrid. You have the compliant. No?
We have the 40 for the left main to LED.
Yeah.
It's a new 3012. Where's the 40?
4
Where's
is
the 40?
here.
Oh, 8. Now, usually left main, recrossing with the used balloon is okay compared to non-left main. Since we used a 30 stent, we are going with the 30 balloon. Any other question, technical questions?
What's the advantage of wiring the circumflex before optimizing port left main?
Before or after?
Yeah, before, like normally everybody does agreed is like doing the port, we optimizing left main and then wire the circumflex. But wiring the circumflex first before
I
dilating the
think
left
it's
main.
just no preference. It's just, I think, operator preference. Like I mentioned, many people will say that here now even the balloon went easy. Okay.
Isn't it
switch
prudent to
down.
put a balloon down the LED before trying to balloon the circumflex, especially since
Yes,
we've not done a
yes,
part?
yes, yes.
It's 4. Get a 3 to 5 high pressure.
Now we have a 40 8 millimeter to the left main, and we'll use the same to do the kiss balloon.
So you first you dilated the circ costume and then sequentially dilating.
Yeah, no, but we are just doing the left main here, 40, because LED
Okay,
is just about 3 or so, right? I'll go
Yeah.
cine.
Okay.
I think they're okay. Okay, go. Can't see if they're right. Yeah, good,
14, 16.
good. Down. And I'm going to go inside and we can now do a kissing balloon. Now this technique also, there will be a lot of people discussing the same, that they would do pot, kiss and repot, but we are not a believer of a repot again.
And I think but two things.
Costume.
No, you can remove the pacemaker, you don't need, and show the hemodynamics, because this is the
6,
most
8.
important point of the case, where Impala will help that prevent any hemodynamic deterioration.
Down.
They should show the
So
hemodynamic on
that's
the.
a kissing balloon. We have done. So you can sequential, right? How are you went for the circ? 18.
18.
18. Yeah. Good.
So the kissing was done with the 4 and 3 balloon or?
Yes,
18.
yes. With the 4, we didn't go high. I mean,
Okay,
ideally,
down.
you want to take another balloon, right, to the LED and
yes.
do a kiss, but we avoiding that step. We just have a 4-0, and we have done sequential kissing. So we'll do imaging right now and show that we have fully optimized stent there. Okay, we can do the IVUS again. What do you think,
Yeah,
IVUS, or you
yeah.
want?
OCT. No, OCT more
OCT?
important. For the circumflex, you have to go further down with a balloon in the circ. Remember, there was still a dent in the stent. Circumflex balloon, you have to go a little further in.
Yeah, there was a dent in the mid portion of the stent in the circumflex.
Exactly. So that need to be opened better. And I think that was just part of the plaque prolapse within to the stent struts. You need to just optimize there.
Keep another balloon ready in case.
Or you can do a little anchor with the LED balloon a little further down.
Now I want to take probably a shorter balloon. It's a 4-0 in the
Yeah, shall we
LED.
take
Same balloon.
So
The anchor will
Go
be
up
okay
here.
with the moderate
Go
pressure.
up.
Yeah, moderate pressure will be okay.
10 only?
Like 8 or 10 here. Yeah.
We just not
despite
change
a
the
12
balloon.
millimeter balloon.
Just not change a balloon. That will be easier.
This is exactly where the
Go
IVUS
up.
also was getting stuck there. Okay, go up here.
But go up here. Go up here first.
No,
Yeah.
no, no, I don't know.
Yeah, you can dilate there
12,
initially.
14, 16.
Okay, down.
And hemodynamically, patient doing fine. When you have double inflation, pressure does go to about 90.
Sir,
Very slow deflation.
Need to dilute.
get a
I
308
think I will
high
take a
pressure.
8 millimeter balloon if you really
Yeah,
want to do
308.
it.
Yeah.
308.
Yes.
Yeah, and see.
Uh, the- Yeah, because I think the impeller helps for keeping it long. Dr. Sharma, what will be recommended time
You-
for
you can,
inflating the balloon?
You can
Yeah,
come and
no,
ask.
Anchoring
we take
balloon.
out at the end of the procedure. Our
No, no,
99%
no.
is
No, they're asking anchoring balloon, how long do you keep it?
no,
So
just
you keep it as long as you are able to cross, that's it, and then immediately deflate.
No, not the anchoring
Sorry.
balloon. Usual balloon inflation. What is the time? That is what was asked.
Oh,
So
sorry.
I know
Sorry,
that there are some data in the literature that prolonged balloon inflation gives you better stent expansion, or if you do a balloon only, gives you better results. But I think it's as long as you are inflated and the dial on your
Go up.
inflation dial that pressure is maintained, it's not going down. So that's okay. Now, many other once you are using a truck coated balloon or any other technique, probably and particularly the absorbable stents, you need to be a longer, but otherwise just as long
14,
as the
16.
balloon inflated and it remain inflated for a few seconds. So our practice has been just 10-15 seconds only, and particularly with the left main, we want to have a shorter balloon inflation possible
Okay, go.
because the hemodynamic issues.
Just a question. Are you working on the fielder wire or you swap this in circumflex?
Down. We're still on the fielder, same fielder wire, yeah. All for the side branch, we always like to use the polymer jacketed wires, fielder. OCT is ready, okay. So we'll take
And
both the
fielder
wires out.
FC. So the question was, should you use a fielder FC or FT? The problem in them is they're easy to go to the side branch, but they don't provide the support. And that is why the usual for the side branch, and that is part of the guide wire app, which Dr. Kini has created, is basically that we try to go with the regular fielder because give the moderate support. Fielder FC and those can go, but then they provide a very little support for advancing the devices. So you want to just show the picture now, Anu, so that we can see the circ.
No, I think let's avoid because we're going to give more dye here. So let's do OCT. If it looks good, then we do a final picture.
So just for everybody, look at the blood pressure of 130.
Yeah.
Anytime they did a balloon dilatation of the left main, and so used to become 80. So that is one of the corollary advantage of these assist devices that prevent hemodynamic deterioration and allow you to do your procedure at ease without the patient or the doctor sweating.
Okay. So you use an IVUS pre-procedure. So is it a practice there to use an OCT or an IVUS post-procedure?
I think
So
ideally you should use IVUS for post-procedure also, but
okay.
There was a demand.
Sharma likes OCT as per demand, he's saying.
Okay.
Just to see, but yeah, coming back, I think we should go to AP cranial view. But yeah, the usual, I mean, you want to use the same device. But in this particular case, but I think OCT telling us good stent expansion with those red color dots and so very reassuring that you have done a good job and there is no dissection.
No, why are we going here? Circumflex. We are in the circ, right? Go down.
Yeah. You want,
Don't listen to him.
you're on circumflex. Want to go on LED?
Okay, let's see.
And remember, the pacemaker is coming in between. We can remove, somebody can remove the pacemaker.
Okay. I was crossed, and let's see, will the OCT make a turn into the circumflex?
Although now it's a different. Now has a
No.
cutting balloon, and stent.
No, still not making it. See that? And I don't think we should try to push or do anything we could have.
Just do it, show it in the LED only then.
Yeah. Okay, I'm trying to see.
Dr. Sharma, about the balloon inflation time, because we all find it's very super fast, inflation and deflation, because there is quite a few people shown in benchmark saying that slow inflation and top complex lesion, leaving it a bit longer time, definitely does break a bit more and gives a better expansion. That's what the general consensus most people feel.
A very good point. So I'll tell you a few data. One is that if you are trying to do only balloon inflation results, so there, we did the trials back in 90s when stent was just coming up. There one was that we used to crack the balloon, go to 16 atmosphere, and then go down to half, to 8, and leave it for 90 seconds. And many cases, which is now my fellows and everybody knows, I do it when I'm not putting a stent. And many times it gives a great angiography result. Second, people used to go oscillation. You go to 16 and you do a little down, 12, then 16. We did a trial called CRACK, C-R-A-C-K, late 90s. So it didn't show much difference. So there are some data of that kind. But yes, as you mentioned, leaving a balloon for longer period of time, 30 to 90 seconds, has correlated with better angiographic result and stent expansion. I saw only the abstract about 6-7 years ago. I don't remember of a paper published, but some data are the longer in balloon inflation. But we know that what we do, we always do 2 inflations. So maybe our short rapid inflation deflation, but 2 inflations, hoping the second inflation will have a more circular, the expansion of the stent may counteract this effect of the long balloon inflation. So yes, if you want to get a good results, the enough data are that 60-90 second may be better than doing a shorter 5-10 second inflation, which we routinely do. So I don't know what your practice is. Maybe you can comment, and maybe other panelists also will say.
From here.
Yeah.
Thank you. I mean, I don't leave at 30-40 seconds, but at least I leave for 20 seconds at least.
Okay.
But
I would say that that's fine. We will do 10 times 2. We always inflate the balloon 2 times with a stent, hoping that there was actually, one time some people used to say, I had never seen any the paper on that, that basically second inflation really gives you more circular expansion. So we'll do 10 seconds times 2.
Thank you.
So you're now
ready?
doing, yeah,
Okay, we're ready for the OCT.
the lady. Yeah.
Left mentality because did not go to SIR. Didn't go, OCT did not go.
Yeah, perfect image. I will check.
Now you show us where the distal left main is, where the stent has covered the circumflex stent, okay?
And then, yeah, nice. Okay, I will show you the detail.
Okay, for the first glance, there's not a single red dot.
Yeah, true.
You see that? Show
And
that
then
a stent.
now I see
First
that this
stent.
is the proximal edge, left main, the perfect expansion, normal position, no dissection, well expanded. And I come to the bifurcation. Now I see the circle on the 5 o'clock. Here's also expanded. This
Do
is
you see the crushed stent?
Yeah, this is osteoid lady. The lumen area is 6.4, well expanded. And go to the distal. Yeah. Through the stand, we're expanded. Then they check. Okay, so this is the distal edge of the stand. Yeah, some small dissection, but or it's on the
I think it's on the lesion.
yeah, true, true. So it's not a dissection.
Yeah,
Yeah.
it's on the lesion. Okay, go back to the ostium. Now, overall, show the full stent,
Okay.
bird's eye view.
Yep.
Okay, see, not a single red
Yeah,
dot, so we
all
know it's
white
fully
dots.
yeah.
So
Yeah.
this is the like clash stent part.
Oh my God, is the expression beautiful.
Beautiful.
Okay, now show me the distal edge of the, sorry, no, not the distal edge, distal left main
Sure.
at the ostial circ.
Yeah, so this is the bifurcation part. I see the circ from the 5 o'clock.
You can't see the crush stent.
1 second.
No, they have it.
You can
You can
see
see
there.
it there.
Yeah.
Yeah.
Maybe around here, like some, yeah, some clash one. Not super protruding, but cover, looks like cover the
Okay. That's good. And then you're saying the left main is well opposed.
yeah, well opposed, well expanded.
Okay,
And
give
no-
us a
Good.
quick CSA. We are good.
Okay, left main CSA is 1 second. Automatically like 7.3. Oh, 1 second. Okay, I checked the detail. Yeah, I can collect. Yeah, 8.6 is the tightest.
Okay.
Good.
I think it's a good result.
Acceptable. Yeah.
Yeah.
The distal edge, can you just make sure the distal edge is okay?
So
Yeah.
I think the inaugural, we have some more time, a few minutes only. Because there's an inaugural function going to happen here. A minister is going to come.
It's
So
on the plug.
Change the settings.
This solid.
can
They can
go
just show the
forward.
last picture.
Yeah, we have some more
We are
time.
done with that.
Yeah, we are going to do a last picture and then
Yeah,
you
sure.
can start your
We have
inaugural
time.
function. Yes.
We have time.
Any other question meanwhile to any one of us? We are giving some
And just-
vasodilator, the final picture always with vasodilator, little nitro. Okay, ready? Good.
You will remove
Start
the
weaning the impella.
Yeah. So that's what question I had. You immediately stop the impella or not after the
Yes,
procedure?
we are going to wean it. It will take about 10 minutes to wean the impella. We will explant the
Okay.
impella here in the lab. We will close it, under fluoroscopy guided up. We already have pre-close. We'll post-close it and then patient will go to the floor or ICU.
I think the angiogram looks excellent. Good result.
And I
Very
would
good.
say that a lot of technical points in this particular case.
Yeah, there are a lot
which
of
were
discussions,
step by step,
technical
yeah.
points. The discussion on supporting the support in high-risk cases. So from my side, Dr. Kinney, Dr. Sharma, thank you very much, and our team at New York for coming at such an early hour and doing the case. So I'll give my
I just have to show you the
Yeah.
contrast use was 140 with the fluoro time of 31 minutes and
Okay.
air karma radiation just about 10. So anything about 2 is reportable, but this was, yeah.
thank you.
Yeah,
And
thank you.
we
Thank you for the
Thank
we
you.
also thank
Thanks
Dr.
from
Anil
Cochin.
Kumar and the CHiP Summit faculty and the audience to be there and I'm able to show this masterful case by Dr. Keeney and the team from Mount Sinai.
Thank you, sir.
Thanks, everyone.
Thank you. Appreciate Dr. Kinney. Thank you very much for coming up on this Thanksgiving Day. It's made a huge difference and we still have a full house here. Appreciate your case and the dedication you showed in so showing. Thank you, Dr. Samin, for holding on from Bombay also. Thank you very much.
Okay.
And
Beautiful.
thank you for inviting us. Bye-bye.
Thank you. Thank you very much.
Thank you, Anil.